Improved efficacy of topical latanoprost demonstrated by corneal biomechanical correcting modified Goldmann prism. The authors have a financial interest in InTor Technologies, also have the listed financial interests. The purpose of the study is to clinically evaluate intraocular pressure reduction measured by Goldmann Applanation Tonometry (GAT) prism and a correcting Applanation Tonometry surface or CATS prism with the institution of either topical latanoprost or alternately a topical beta blocker. The correcting Applanation Tonometry surface or CATS prism is an FDA-cleared replacement prism for measuring IOP in any Goldmann tonometer. It differs from the Goldmann primarily in its contact surface, shown here as being centrally concave. The surface has been demonstrated to simultaneously reduce all biomechanical errors found in Goldmann. 72 treatment-naive glaucoma patients were randomized, 36 in each group, to treatment with latanoprost or timolol maleate. Each patient underwent IOP measurement with standard GAT and CATS prisms before treatment and at 1, 3, and 6 months of treatment. The central corneal thickness and corneal hysteresis were simultaneously measured. Medication response was defined as a 20% reduction in IOP from baseline. Well-matched latanoprost timolol cohorts are shown here. The CATS prism demonstrated the IOP reduction with topical latanoprost at 6 months at an average of 1.9 millimeters of mercury lower than the IOP measured with Goldmann. The CATS and GAT prisms detected no statistical difference in IOP reduction with timolol. Latanoprost generally outperformed timolol in both CATS and GAT measurements. The number of latanoprost treatment non-responders was reduced from 36.1% measured with Goldmann to 13.8% when measured with the CATS prism. Timolol indicated no difference in the treatment non-response rate at 22.2%. Corneal hysteresis increased significantly with latanoprost treatment at an average of 0.55 millimeters of mercury and remained unchanged with timolol. This graph illustrates the greater prostaglandin IOP drop demonstrated by the CATS compared to the GAT prism. We know that IOP versus CCT slope decreases with decreased prostaglandin corneal rigidity, and the IOP decreases with prostaglandins, as we would expect. Also, we know that the CATS IOP versus CCT slope remains relatively flat, and the CATS prism was designed to measure the same as the GAT at a CCT of 550 microns. Therefore, the greater CATS IOP drop is due to the greater CATS minus GAT differential tonometry before prostaglandin analog treatment, with the increased GAT slope illustrating the increased corneal rigidity. Improved IOP reduction and responder rates were demonstrated with a CATS prism in patients using latanoprost and not with timolol use. Latanoprost-induced reduction in corneal rigidity likely reduces the actual IOP reduction measured with a standard GAT prism. Studies measuring IOP as the primary endpoint, such as medical and surgical interventions, should include some correction for corneal biomechanical alterations which create significant error in Goldmann Applanation tonometry.